From the JAMA Network, this is JAMA Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Hello, and welcome to JAMA Surgery Author Interviews. I am your host, Dr. Jamie Coleman. Today we will be discussing another fantastic article, which is also a pretty hot topic. We are here with the authors of the paper, Obesity Treatment with Bariatric Surgery versus GLP-1 Agonists. The authors joining us today are Dr. Tyson Barrett and Dr. George Ide from Highmark and Allegheny Health. Welcome to the podcast.
Thank you. Excited to be here.
Glucagon-like peptide-1 receptor agonists, GLP-1s. I feel like you can't go anywhere anymore without hearing about these drugs. But your paper really tackles what I think is the biggest question on both our patients' minds and other physician minds, which is, how does it compare to what has always been our gold standard of obesity treatment, which is bariatric surgery? So to start, I'll direct this first question to you, Dr. Barrett. Can you please share with our listeners some background regarding your study? What was your methodology? Who was included? And how long did you follow them?
Yeah, I would love to talk about what we were thinking. As we went into this study, we had the exact same question that you brought up, where we really wanted to understand how do these compare, especially in more obese individuals. So our research questions kind of stem from, can we take a look at both healthcare outcomes as well as health outcomes? So we want to include costs and utilization outcomes, but we also really want to understand how are they doing clinically, particularly with weight loss. So our study was retrospective. We were able to use our really cool claims database that we have here, and we're able to link that with electronic medical record data. Those together help us really get a full perspective of the patient's health and well-being. And so for us, we were able to use both of those. Our full large sample with claims was over 30,000 people. We were able to follow them for at least 12 months after starting to use the drug, or at least 12 months after their surgery. We were able to join that with quite a few electronic medical records as well.
Can you tell me a little bit more about that claims database for someone who may not be familiar with that?
Yeah, I love that question. It's one of the things that we are excited about that we have here, because it gives us a viewpoint into any reimbursable healthcare encounter. So for covered members of Highmark, we're able to understand participants' healthcare behaviors, so we can understand if they're needing to go to the ER or inpatient stays, whether they're within your healthcare system or outside. And with all that together, we can really understand what is happening with members' health and well-being beyond what is generally available in an electronic medical record.
That's great. Such a wide-ranging catchment area, in a sense, where you can really get a full picture of how patients are using the health system. And so you've got this retrospective cohort of 30,458 patients, which is amazing. And so it sounds to me like you've almost got kind of two categories for your outcomes. It sounds like you were looking at weight loss, but then you also looked at cost. So let's start with weight loss. What can you tell us that you found?
Yeah, for our weight loss outcome, what we were most interested in was just comparing the two, both in terms of just raw weight loss, but also we wanted to understand percent weight loss and also pull that into excess weight loss. All of those outcomes are obviously really related, but they help us understand a full picture of how much they're losing and how much of that is actually getting them closer to a target healthy weight. And here, the bariatric surgery group performed very consistently better than the GLP-1 group by a decent margin. In fact, when we broke it up into just categories of like 10% of sustained weight loss versus 5% versus less than that, GLP-1s produced about 45% of those members had about 10% weight loss. For bariatric surgery, we saw that at 96%. So over double the number of people that had 10% or more weight loss. And that number is very similar with 5% sustained weight loss as well. So what we saw in the 2 years that we were looking at follow-up after either the surgery or starting to use GLP-1s, we saw a much higher sustained weight loss in bariatric surgery.
Dr. Ide, can you tell us a little bit about how this translates to the patient? Because what I'm seeing on your data here is overall GLP-1 patients lost about 10% from their starting weight overall, compared to over 20% with bariatric surgery.
So this data is not surprising that bariatric surgery is more effective than GLP-1 in the group that we studied. But I would like to go a step further is when we looked at the cost comparison between the two, also bariatric surgery was shown to be more cost effective. But let me pause for a second and tell you what's behind those numbers. If we look why this was the case, it's because inpatient stay was around 25% less, outpatient visit 27% less, ER visit around 38% less in the bariatric surgery group as compared to the GLP-1 group. So while the study is retrospective, but we can fairly to say make conclusion that also their health improved. So we have the effectiveness goes beyond the weight loss and show us that there were other benefits to bariatric surgery than just the weight loss portion of it.
And I think that's what, to me, is probably one of the most surprising aspects for people, because I think inherently they think, oh, a patient got surgery, they're going to be in the hospital more, they're going to be in the emergency department more than someone who didn't undergo bariatric surgery. And so I just wanted to highlight that finding because, like you said, that's really what drove a lot of the difference in costs.
Absolutely. And keeping in mind that most of our patients in the study we did were BMI 40 and above. So keep that in mind whenever we are interpreting this data, because at the end of the day, we're in the early innings of a new, what I call revolution in obesity care, trying to understand who would benefit from what, in a sense. And this data plays a major role in that patient category group and how they benefit from bariatric surgery in a major way.
And over a period of time.
And that's more important, is that we have data that follow up to 2 years afterwards. They're still showing the benefit of what we have. We know from other publication in the past, we have long-term data on bariatric surgery, and we don't have it on GLP-1 yet. But even the early data, even the short-term data is still showing the benefits of the bariatric surgery.
Was there anything in the data that surprised either one of you?
You just mentioned it. We just talked about it. I mean, to me, less ER visits, less hospital utilization, all of that was, to me, another proof of surgery is safer than it ever been.
So you mentioned this changing landscape that's happening. There was a recent paper that was also published in JAMA Surgery last month that actually just looked at the use of GLP-1s in patients after bariatric surgery, which is becoming increasingly common. What are your thoughts on this as a practicing physician yourself?
Jamie, this is a great point that we need to keep in mind. I would like to remind our listeners that this is also not about surgery versus medication. In every disease state we know, in the medical field, we have different interventions to treat a disease. This is not new. What was missing in obesity care was effective medication to help us take care of things. When we do cardiac surgery, we don't stop that aspirin, correct? I'm just kind of like a small example. So same thing with GLP-1 and bariatric surgery. Obesity is a heterogeneous disease. Not everybody responds the same way. Not everybody will have the same effect. Some patients will require surgery. You have a subgroup where medication probably will be sufficient. And then you have the other group where combination therapy is the way to go. We still have things to learn, and I would love to see more publication coming out, more quality paper coming out in our plight to reshape obesity care.
So to put it in perspective for our listeners, some of which are going to be physicians who are on the front line of obesity treatment here in the United States, they've got a patient coming in. The patient is over the BMI of 40, as you mentioned. So it's someone who you've studied, who looks like the patients that you're very familiar with. They also have complications associated with their obesity. Where do you start with this patient? What do you suggest to that physician that their starting approach? What should it be?
The first thing we learn as physicians is to make sure we educate our patients. Patients have to have a real informed decision-making process. So it's important Our paper is one of those information that we need to provide to our patient and say, look, if your BMI above 40, these are your expectation. If you were on medication, this is what you expect. If you go on surgery, that's what you're going to expect. So it's a way to say that for higher BMI, we have more evidence coming out showing that bariatric surgery is more effective. At the end of the day, patient has to be convinced of the right way to go. And it's our job to educate them about the different treatment options available. So that's where we start. But this paper, and hopefully more to come in the future, I guess stay tuned, that will help us even make better and more informed decision for the patient.
And so what does that future look like? What else do you want to know? What are the questions that you still feel like need to be answered in this area of GLP-1s and bariatric surgery?
What I'm most interested in is understanding if we can better predict who can benefit from what early on. So we don't have to go down as many paths to eventually get to the best treatment for a patient. Ultimately, we would love to find that treatment as early as possible in an informed, evidence-based way that allows us to really kind of find the most effective, quick, most cost-effective ways of helping these patients recover and ultimately become healthier.
And Jamie, if I may add, I'm sure you're all aware, but just to put it into perspective, just by 2030, it's estimated that 50% of the population will require some form of a treatment with a BMI at 30 or above. So we're talking about scaling a treatment. The good news is we have effective treatment options. That's the beauty of bariatric surgery, and a welcoming addition having the GLP-1 in there help with the fight of keeping patients living with obesity. The question is how we can scale that. That's a big task. That's a lot of resources that's needed. So research like that and data like that to help us, like Dr. Tyson mentioned, to find out what works best for the patient and try to avoid quote unquote unnecessary treatment from the get-go.
Well, I look forward to hearing more in this area. I look forward to reading more, I'm sure, of your future research as well in this area. Dr. Barrett and Dr. Ide, thank you so much for joining me today to discuss obesity treatment. Our listeners can find a link to your article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for listening. Have a great day, y'all.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.